So minimal residual disease, or MRD, is really a sensitive analysis of depth of remission. So we have a variety of techniques that allow us to detect down to 1 in 10,000, 1 CLL cell in 10,000 cells, or even more sensitive as we move forward. The IWCL response criteria have used 1 cell in 10,000 as our MRD negative definition. The challenges with MRD are what tissues to look at, so peripheral blood or bone marrow, and whichever you look at, they are prognostic. The better remissions result in better outcomes, but if we're moving towards a curative approach where we can stop therapy, we probably need to look at marrow as well as blood. So MRD in CLL has really been used as an important early assessment of response, because we get the results very soon after the treatment rather than waiting for progression, and also showing that deep remissions can be achieved. So it's probably the most important predictive outcome. For example, following chemotherapy, the patients who are MRD negative do better than both in terms of PFS and survival than the MRD positive patients. We're now moving towards using MRD to define duration of therapy, so that we can, with the targeted therapies, rather than have continuous use of treatment when patients eradicate disease where we can't detect it, to stop therapy and give them at least prolonged periods off treatment, potentially indefinitely.